Welcome to week 6, our final week together. Excuse me for just a moment. It's been fun. All right, we're going to talk a little bit about, and this is actually my favorite lecture, as I mentioned before. It is high-risk labor and delivery. It's where all the action happens, right? We're going to talk about some complications that occur. We're almost done. We're almost to the end, and right at the end, we get some trouble. These are the things that we're going to talk about in detail. The first one is prolapsed umbilical cord. Prolapsed umbilical cord is the reason why I have you doing a vaginal exam or check the fetal heart rate after the water breaks, because for distress, because we don't want the cord to have come down and then the baby's head pressing down on it, okay? So I think that one of them goes that way, this one goes that way, this one goes this way. Okay? There we go. I don't know if you got that or not. Okay. So water breaks, gush of fluid, umbilical cord comes down, and then the head comes down and pressing on it. Guess what? Baby doesn't like that. All right? It's not a comfortable place for the baby to be in. All the oxygen is being pinched off. All right, so this is the deal with that. I have a story. And the story goes like this. Lovely, lovely couple having a baby. Oh, we were having such a good time. But mom was like, I don't remember what she was, like, I don't know, 6 centimeters. I don't remember how much she was, but she was plugging along, her water broke, boom, 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 heart rate down. Well, being the good nurse that I am, did a vaginal exam, and I could feel the pulsating of the umbilical cord across the baby's head. So, what you have to do when you feel that is you have to push up on the baby's head to try to relieve the pressure on the umbilical cord. And you can't leave. You have to stay there and do that. So I got her up on her hands. I had tried to get her up on her hands and knees first because just to get the heart rate up. And it went up nicely with the hands and knees thing, but I still needed to check. Found the cord there. So she's on her hands and knees with her butt up in the air, and I am pressing the baby's head up off the cord. And as long as this is how we were, the baby did just fine. The baby was looking lovely, but there was we had to stay just like that or the baby started protesting. All right, so we're not going to deliver vaginally. We're going to take this lady to the C-section room. And it was in the afternoon. I was working an evening shift for some reason. And everyone was there. It wasn't an emergency. It was unplanned and, not emergency, but urgent. Just not like we had to run down the hallway in this particular case. So they were taking their time getting ready, making sure everything was set for the patient. And then it came time for me to get her down to the OR. And they're like, okay, get into bed. I'm like, excuse me? And they're like, you have to get in her bed with her. Because you can't fit out. A bed and a person next to the bed cannot get out of a regular room. I was like, I have to get into bed with her? Like, I don't know why that, of all things, was trouble for me. Okay, climbing up in. So we're getting settled. Again, we're laughing because everything looks fine. So I'm in bed. We're draping. Our union was covered with a drape. And so we're laughing like, this is just kind of funny. The way we've been just sitting there chatting after a while. And I'm butt up in the air, my fingers in her crotch, Anyways, I'm into bed now, all right? Picture this. Lady, head down on her pillow, butt up in the air, right? Down like this, me behind her, right? Sheet draped over, kneeling behind her. So we're coming down the hall, and we see like the entire OR staff, like waiting for us at the desk, and we're like, oh gosh, my gosh, this is kind of embarrassing. Like, she's like, who's more embarrassed? I'm like, to be honest with you, I'm not sure. This kind of stresses me out a little bit too. You know, we're joking around a little bit. So we decided we're going to just look straight ahead, be very serious. And then right at the last minute, we were going to wave to them. So again, she's got her head down. I'm just very serious, walking, you know, getting wheeled past. Just as we're passing, both of our hands go up and we're like, no. We go through the OR. Big roar and laughter, and then that's the first part of the story. The second part of the story is, so now we're in the OR. Well, it takes a little while to actually get the baby born once you're in the OR. She had an epidural, so they just dosed the epidural up. But now she has to get onto her back. So it gets all the more important that I'm in there pushing the head up off the cord. Oh, all right, well, so I'm in the way? Oh, excuse me. I guess I'll just get under this OR table and, right? So now I'm down. They're like draping stuff over me. As long as my hand's up and in there, right? So, I don't know, somebody tried to contain my hair up in the thing, and they're getting everything all draped. It's hot down there, I gotta tell you, it's really hot. And then you start feeling a little left out, you know? At one point, I'm like, guys, do you remember I'm down here? Like, oh, yeah, whatever. The doctor who was in there, who was my absolute favorite doctor, he's like, Libby. He was from St. Thomas. He loved him to death, Dr. Gums. Libby, are you touching my leg? I'm like, yes, actually, I am touching your leg. Not just touching your leg, I'm like holding on to his leg. The suction tubing the dry suction tubing was down around my shoulder, which I didn't feel in all the stuff until it started sucking out a large amount of body fluids, and it felt like just body fluids rushing down my back. I was down there like, that's all you could hear. They're like, it's tubing, Libby. I can't feel my hand anymore. I don't know what it's doing. I do know that I was sweating through my scrubs. And I was hoping that it was working. But nonetheless, they finally get in there, which seemed like hours, and got the baby out. And I could feel my hand because what I felt was the doctor going beep beep. Like, so twice my hand's been in situations that I didn't expect. You know what I mean? The sucking of the fingers a couple weeks ago, and the flick 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 of the finger from the inside. Okay. Anyways, I come crawling out from underneath the OR table. They're all looking at me laughing. The baby's fine, mom's fine, everyone's fine. It was just one of those interesting stories that I feel like I need to tell you. Yeah, maybe. I felt bad. I'm like, geez, is there any chance I could actually just like poke through his soft spot? Moral of the story is stay in the vagina. Okay, folks? Just stay in the vagina. And from this point on, what is this? The peace symbol? Not anymore, folks. Know what I mean? Not anymore. Every time you see the peace symbol, you're going to think of me. And my words of wisdom, stay in the vagina. Okay, that's what you're going to do when there's a prolapsed cord. You're going to stay in the vagina. People have taken their NCLEX and gotten a question like that and immediately either texted or emailed. See? I know I got that question right. Stay in the vagina. Anyways, there's that. So, if you see me, say like at your pinning. Because I sit front and center, right before all of you, all serious and you're white. And I might be listening intently to the speakers or whatever and just be like, Or I might just come right out at it. You will know what I mean. All right, there's the cord. That's what you're going to do. So the ones who are at risk are the ones who have a lot of amniotic fluid. So when that bag of water pops, right, a big gush of fluid comes. Anything can kind of come down in the rush of the fluid, right? A baby who's not quite engaged in the pelvis yet, slightly off center or very small. The cork, there's not a cork in the bottom, so to speak, right? So anything can kind of come down and around if it's not really applied into the pelvis. I have had, under different circumstances, preterm patients come in, like very preterm, with ruptured membranes and umbilical cords hanging out of their vagina, which is not a good situation at all. They came in that way. So, yeah, that's not good. But the same applies. You go and you push whatever the presenting part is up off the umbilical cord. You can do all of this too, as long as you remember. Yeah, we're gonna support mom throughout all. In the meantime, prep her for surgery. Right, so you're gonna call in the enforcements to help with all that, and we just have to ensure mom and baby's health and safety as best we can. There, picture me behind her. Yeah, picture me under this OR here, OR table there. Yeah. All right, meconium stained fluid. Meconium stained fluid is, I think we kind of talked about this, the pea soup, yeah. So the issue with meconium is that it's no big deal that the baby pooped ahead of time, because maybe they're just ready to poop. But if it's really, really thick, then they've pooped a number of times, which means they're probably stressed out. That's why they're pooping, all right? So they might already be a bit compromised before any of this gets started. So that's not good. The other issue is if it's really thick, they're going to be breathing that stuff in with their first breaths if we don't try to minimize that with suctioning and whatnot, okay? So that's really the issue with meconium stained fluid. It can usually, if it's a thick fluid, the pea soup kind, we will call pediatrics in for the delivery, just to be there to intubate the baby. If the baby's not having spontaneous respirations, we will intubate and deep suction past the vocal cords to try to get up anything that is in there before the first deep breath. This is the baby we're not going to stimulate right away. If the baby is not breathing, we're going to whisk the baby over, lay it down, and deep suction as best we can. Get out all that stuff as much as we can, and then we dry and stimulate the baby, okay? If they are already vigorously crying, deep suctioning past the vocal cords just causes irritation and more damage. And the damage is done. They've already taken that big expanding breath. So we just watch those. They might even get a chest x-ray. What we're concerned about is a meconium aspiration pneumonia on baby. All right, so we'll put the baby on monitoring for infection, basically. Yeesh. Huh? That's what we're talking about. That looks like pea soup, doesn't it? So a couple of different things. The baby who is overdue is just ready to poop, and that's why they're probably pooping. A baby who is stressed, has a hypoxic episode or two, will also pass meconium. It could be cord compression. The hypoxia stimulates the vagal nerve, and that's what gets them to poop. All right. I think I mentioned if the meconium that's coming out looks like what you find in the diaper, most likely there's a butt presenting, not a head. Does that make sense? So the butt is literally just pooping right out of the cervix. The butt down. If it's coming out looking like what you see in the diaper, it's not mixing with amniotic fluid or anything. It means that it's not probably head down, it's butt down, and the baby's just pooping out her vagina. Good times. Good times. Yeah. Sometimes the baby tells us in another way, and that's with the heartbeat, right? That they're not feeling so good. We see that there might have been trouble when there's meconium fluid, and then they're showing us with decelerations and whatnot on the monitor that I'm still not doing so good. You know, so those are the ones we're really preparing for a full resuscitation with pediatric presence at the delivery. Every delivery, we try, anyways. You know, the ones that happen in the elevator, we can't quite get to, but every delivery in the delivery room has the equipment necessary for a full resuscitation of our newborns. All right, that's part of setting up the room. All right. If we have thick meconium fluid and a bunch of decelerations, peds on their way in, I'm going to be triple checking that all the equipment's ready, because now it's not just what if, it's when we're going to need some of that equipment. So we'll get it all ready and set, making sure we can do that. And remember, if the baby is vigorously crying at the time of birth, much of what our plan to deep suction and all that gets thrown out the window, because we're just going to cause damage in the deep suctioning. Fetal distress is a number of things. Usually it's it's the heartbeat, the pattern of the heartbeat that indicates the baby is under distress. That's the only way our second patient can talk to us, is through the fetal monitor, and we need to listen and pick up on even the subtle signs, if you will. And it could be from an anomaly, either fetal or uterine. It could be from any complications during pregnancy, labor, or birth. We're going to just do our best to ensure the safety of both mom and baby, right? We're going to do the intrauterine resuscitation. Sometimes it's a balance, and I think, Sarah, your patient, for a brief time, the baby said, oh, no, I don't like that pushing. I don't like that pushing at all. And so they stopped everything to try to get the baby rest and the best oxygen as possible. So then it becomes this balance, like we need to get the baby out, but the pushing and the contractions and all that are causing the baby stress. And so we just have to figure out, can we get the baby out safely? Is it less of a risk to do that? Or should we try to stop everything and take the baby to the C-section room? You know, take the mom to the C-section room to deliver the baby that way. I mean, we don't ever 100% know, but if the pushing is going well, baby just doesn't like it, we might opt to push through a little distress rather than prolong the distress to take to C-section room. If they aren't hardly pushing or they haven't even gotten to the pushing stage yet, first time mom, might be hours and hours and hours. We're not going to sit and watch that baby under distress. We're going to take her to the C-section room sooner than if it's right at the end. Does that make sense? Got to look at timing. It can be pretty stressful for everyone involved. Just, are we making the right decision for mom and baby? And then you have some dystocia. Dystocia is dysfunctional labor, plain and simple. Labor's going along. It might be like just really tumultuous labor, and then it just kind of like stops. Maybe the contractions weaken, and just kind of maybe peter out. Well, then we usually try to get them started again. We'll wait to see if the body's just doing some sort of rest thing on its own, and then we'll kick back in. But we're not going to If labor has already been established, we're gonna, augment it along if we can. I always like to just take a moment and look at the whole picture. Why is the body stopping? Why did the body say, oh, I've changed my mind, I can't do this? Let's look at mom. Let's look at mom's situation. Let's look at how big this baby is. Let's just take a minute to say, is there a possible reason why the body stopped? Is it because the body knows it can't do it? And I like to just take a minute before we get blindly into, let's get labor going again. Sometimes we need to look at the whys and the whats in the hows.
It's going through the transition phase.
Maybe, yeah. The body itself is saying, you know what? I can't do this. I don't want to do this anymore. Yeah. Certainly, risk factors include old, short people, apparently. I know, with uterine abnormalities. A big baby. Babies whose head is too big for the pelvis, CPD, cephalopelvic disproportion, okay? Sometimes it's the baby's just not, the head is down, but it's just off a little bit, and it's just not coming out the proper way. Sometimes there's more than one kid in there that we're trying to get out. Sometimes it's just been in labor for too long. Sometimes it's we intervened too soon. So mom was uncomfortable, we wanted mom to be comfortable, so we gave her an epidural. We gave her an epidural when she was only 3 centimeters, when really we would have preferred 4 to 5. And we knocked out her contractions because she was just not far enough along. So sometimes there's a good reason for it. Sometimes we just have to take a moment and see if the body's telling us something. All right? Hypertonic uterine dysfunction. That's when this lady's contracting. Boom, 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 one right after the other. There's a couple of issues here. That muscle, right? That uterine muscle is going to get gosh darn tired doing that. And is it going to be able to hold up? Who else is going to get tired with that? A baby. The baby is not going to get a good amount of oxygen with very little rest in between. Remember I said uterine relaxation is when the baby is receiving the most oxygen? So if there's very little to no relaxation for all of these contractions, then this baby's going to begin to protest if it's not already. So it's just so it doesn't mean the labor's moving along quicker and it's going to get over with any quicker. I mean, it could actually end with a mom and baby who are experiencing some deficits because of the strain, physical strain of the rapid contractions. Call it tachysystole, which is about the contractions just one right after the other. Hypotonic uterine dysfunction, that's when we kind of peter out, okay? When the contractions slow down on their own with no apparent reason. One way or the other, generally, this dystocia means lack of progress. The cervix isn't dilating, despite contractions or despite the contractions having been happening before and now going away. All right, we just have to figure out what to do. I'm gonna do all of these things. Maybe give this mom a break. Maybe it's just needs a break a little bit. And I'm all in favor for realizing that the body might know something we don't at this point. Let's give mom a break. Let's relax her a little bit. If everything else looks okay, let's just slowly make our decision about how to progress, so that maybe if it's just that everyone needs a break, then we can do that. Then there's shoulder dystocia. Shoulder dystocia is when the baby starts coming out, the head comes out, but the shoulders get stuck. this is a nightmare scenario for good many people.
I saw this before.
Right.
It was scary.
Very
It's
scary.
an emergency situation.
Mhm.
Everything came flooding in. At the time, I didn't really know what was going on.
Mhm.
Figured it all out after. I think it was explained to me. I was like, why isn't the rest of the baby coming out?
Wow. Yeah.
Like I was, like the way that they were put, I thought the baby was like decapitated, but like the way that
Yeah.
they were trying to. Eventually, he ended up getting out. But because he was 9 pounds, 10 ounces.
That's a big baby.
The mom was short and a lot of the things you just talked about.
Right. Yeah. Sometimes we don't realize the baby's going to be that big, or I don't know. It's hindsight is certainly a clearer vision than if you're making decisions in the present. But it's pretty scary stuff. There's a couple of things that we can do to try to fix the problem, which you probably saw and had no idea what was going on. You thought that we were torturing mom in there, right?
They kept maneuvering her legs,
Yeah.
trying to find like
The first is McRoberts maneuver. And who saw the ER episode? I know my one group didn't, but we're going to watch it next week. Now that I paid for it, right? We're going to watch it. $2.99, Amazon Prime. So everyone else watched the ER episode. So the first thing we're going to do is McRoberts maneuver. McRoberts maneuver is hyper-flexing the knees up basically to mom's ears. We're going to push on her legs upwards, bent and upwards. What that does, it kind of widens the pelvic arch as much as it possibly can be widened. All right? Somebody else is going to come along up on a stool, so they have good height above everything, and take their fist and press right above the pelvic bone. Press with all their might down right there. What that is called suprapubic pressure. And we are trying to push the shoulder underneath the pelvic bone. There's some maneuvers that the practitioner's supposed to be doing, trying to rotate the baby's head. That's called the wood screw maneuver. Trying to do that to try to release the shoulder, move it out of the way, that sort of thing. And then, as some of you remember from ER, Zavanelli's. Zavanelli's is pushing that head back up into the uterus and taking her to the C-section room. Yeah, pretty nasty stuff. So, another story. Woman comes along. She is moving along quick. It's her 4th baby. She's got 3 girls at home. She doesn't speak English. She speaks Spanish. So I'm moving along with her, communicating as best as I could with her. And I didn't trust her. I knew she was moving along quick. I knew she was going to... the doctor was at home, naturally, middle of the night. So we called the doctor saying, she's moving along quick. Get here as soon as you can. And then I go to get I have to set up a delivery cart and all of that. But I don't even trust her to turn my back on her. I think that when I say trust her, she's a nice lady, I'm sure. That's not what I mean. I mean, I just felt like, even though she was 6 centimeters, I feel like we were going to have a baby in the next couple of minutes. So I got the cart out, and I'm getting my gloves on, and I'm like setting up the cart as quickly as possible, I'm sure in complete sterile fashion. And I'm just on the cart, I'm looking for the things I need to deliver this baby. And because that's all, I'm not a drape, sorry, that's not going to happen. I need my bulb syringe, I need this pair of scissors, and Sure enough, baby comes flying down her. The passenger descends through the passage rather quickly. So I turn and I deliver the head. And because I already had sterile gloves on, how convenient. And I'm trying to get help in the room, because it's just me and the patient. I'm like trying to, can somebody help me? Pressing the button with my foot. So somebody press, hello? All right. So the head's out. And the next thing you have to do is you have to get check the neck for a cord. And there was a nuchal cord, we call it, cord around the baby's neck. And if you find that, you're supposed to try to get it up and around the baby's head, reducing the nuchal cord. Well, that cord was strangling the kid. It was very, very tight around, and I could not pull it loose and get it around the baby's head. So you're supposed to clamp and cut the cord, and then, baby can come out. So I clamped and cut the cord, and the damn baby got stuck. I'm not blaming the baby. But I just cut off the baby's oxygen, and the baby was stuck. Just then, some coworkers of mine decided to join me, and I said, "We got a shoulder. So I was like, "Oh my gosh!" And so they broke into action, getting those legs back, pressing, doing all those things. About 3 weeks before that, I'd gone to a conference on OB emergencies. And though I am a very good student, paying attention to every detail, like you guys do. And so I'm listening to everything, and they're talking about all the things that the practitioner's doing. While I'm pulling back and pressing down, it talked about everything that happens in shoulder dystocia. Good thing, because no practitioner, it was me at the helm there trying to get this baby out. So Mick Roberts' maneuver wasn't working. Suprapubic was not working. This kid was stuck and turning a god-awful color. It's not a very pretty color to begin with. It's kind of a purpley blue. It was getting darker and darker on me because the kid had no oxygen. So I reached back 3 weeks into what I learned at the conference, and I remember, okay, wood screw maneuver. I'm going to try to rotate so the shoulder gets under, maybe out from underneath the pelvic bone that way. Nothing. The kid was wedged in there good. And then I remembered one more thing. And I reached in, I swear to my elbow, reached into her uterus and hooked my finger around the baby's armpit. So we're talking, I'm in there quite a ways. And I grabbed the kid's armpit, the bottom armpit. So this shoulder is what's stuck. And I reached for this armpit. I got that arm, and I pulled that arm out. And in doing that, the shoulder dropped, and I got the kid out. Yeah, well, because in getting that arm out, it just dropped everything down a little bit. The child had no spontaneous respirations, no cardiac activity at the time of birth. Was black in color because of the lack of oxygen, and very, very limp. So over we go to the warmer. We didn't have to worry about clamping and cutting the cord because I already done that. Chest compressions, positive pressure, and the kid came back very quickly, and seemed to be fine. So we did maybe 30 seconds of chest compressions, and the heartbeat came back. And I was the one doing the positive pressure, and I just kept doing it. I mean, I got what seemed like an hour, which was probably no more than a couple of minutes. But I was like, I got some making up to do with this kid, so I'm going to just keep giving this kid some, I don't know. And it was just then that the doctor came in.
Wow.
Oh, I heard one of the nurses in all of this. I could hear her on the phone calling the emergency room and saying, "Get the doctor up here right now," the ER doctor. And then I turned to her. I said, "Well, what's that gonna do?" Like the ER doctor, because if a baby dies, we need a doctor in the room. I'm like, oh my gosh. I understand that, but I was like, I just killed this baby. Oof. The longest, 3 minutes of my life.
This is a stupid question, but wasn't the cord really long because you cut it at his neck or no?
Well, it was all still stuck in
Yeah,
there. It was all in there, yeah. Oh, yeah. I don't know. I didn't care. No, it was got a clamp hanging off the end of it.
I just thought about the cord.
Yeah. Nah. I don't even remember about the cord, to be honest with you. So I'm still doing positive pressure ventilation. Both the ER doc and the OB doc walked in about the same time. And they had no idea what was going on. They had no idea the stress of the last few minutes. And none of it was their fault. None of it was their fault. Anything, I felt like it was my fault. Oh, gosh. So anyways, the doctor comes over, And I'm usually fun-loving, as you can imagine. Not that day, not that moment. And he's like, hey, Lib, strike one. No, we're already up to strike two. Strike two. You weren't, like, immediately available from your home and got, you know what I mean? Like, of course he wasn't. There was nothing going on, no patients, and then boom, patient delivering, you know. Anyways. And strike two on that. And he said, I think you could stop positive pressure. The kid is trying to rip the oxygen mask off her own face. Anyways, the kid was okay. The nurse who had gotten the ER doctor up there was a mentor of mine. She was also my landlord and kind of a second mother. And she was the one taking care of the baby in the nursery afterwards. And I was still a little shell-shocked, you know. I thought for sure I'd killed a baby, really. So I came in after I changed because I was a complete mess. And she said, did good in there. You know, a motherly people. You did good in there, kid. I said, I don't know. She goes, at one point, you were looking to me, you were looking to the other nurse. I saw some panic in your eyes. I said, yeah. And the other nurse said, when I saw panic in your eyes, that's when I panicked, because you never show panic. So they got one nurse panicked. I saw some panic in your eyes, but then I saw you look up. And then you looked back down and knew what to do, and you did it. And I'm like, I gotta go. Off I went. So the kid's fine, I guess. I don't know if she's top of her class or anything. I don't know. There didn't appear to be any. I know. There did not appear to be any deficits. Nothing. There did not appear to be any deficits from the moments without oxygen.
Was it May 20th, 1993 by chance?
Oh, no.
That would explain a lot of my life.
No, sorry, it wasn't. I had already had a baby. I know that. Was that you, personally?
That was
Oh.
that was kind of the joke I was making.
Listen to me, I'm like, oh, shoot. Oh, the kicker is I finally turned to the parents, and in Spanish I tell them, it's a girl. Everything's fine. It's a girl. And it was their fourth girl. They were like, oh. My God. I was like ready to kill everyone in my path. But it's a living girl. I almost killed your baby, but I didn't. It's a girl, yes. I'm sorry. Oh. That was a lot. Anyways, the problem with, and I know you can tell, Amber, right? You can speak to how you feel like the head is going to come out and nothing else because of these. And sometimes what happens is, yes, we break a clavicle on the way out. And the other thing that might happen is that we might stress and the brachial nerve, the plexus nerve, and because of stretching. We are pulling down trying to get that shoulder out, and the shoulder's not moving, but we're stretching that neck there, and that's you, right? And there can be permanent damage, even if the baby does come out. If there's
From that really bad color that you were talking about, I was like, my heart, like, it went from like me being like, oh my God, I'm gonna see this baby born, and my heart just sank. I'm like, this doesn't seem like this is going well.
Yeah,
at all.
very scary
Even
stuff.
after the baby came out like quiet, they had to like, they plopped the baby on the mom's chest for like a second and was like,
Wow.
"Here's your baby, congratulations, but we need to take him." Like, and so they
Yeah.
took him over, they sectioned him, they did a lot to it. I mean, I was kind of just focused on the mother because there
Yeah.
was, I couldn't even tell you, I feel like there was like 15 people in the
Yeah.
and there was panic.
Yeah, there sure was,
I
sure.
felt so bad for the mom. It was the mom's third baby, but it was the dad's first.
First.
And you could just tell he was so concerned about like his wife and the baby. It was definitely
Yeah.
a stress situation.
We really, every day, I've been in on thousands of babies born. It's just such a miracle, and I still find it to be such an honor to be there. But I think even more so is because I know when things can go wrong. You know what I mean? I'm not if I can be this blunt, I'm not paid to hold people's hands and celebrate with them. It's nice, and I do that well. I'm paid for the knowledge and experience that I have when it does not go well, and I'm not holding her hand because I'm resuscitating her baby and, stuff like that. Tough stuff. All worth it, but it's tough stuff.
What's the time frame between lack of oxygen and brain death?
I think it varies.
Yeah.
It also depends on what kind of reserve the kid had in there ahead of time, and I really don't think it was that long that I was in there doing all those things.
Right.
To me, it was a long time.
I'm sure.
Do you know what I mean? I literally thought that I had killed a baby. And I was going to take it very personal because I am the one who, you know what I mean? I don't know if the doctor would have done anything different.
Right.
And even when I was trying to explain, I said, I will explain, let me clean up and then I will tell you what happened because I needed to. And when he said, you did what? Like he didn't, I said, I delivered the posterior shoulder first, and that dropped the anterior shoulder, He said, wow, oh. Like, do you not, did you not know how to do that? Well, if you want me to teach you, I can, I don't, anyways. Or maybe you're just having, I don't know. Anyways, so things can go bad. Things can go bad pretty quick. I think what happened to this kid is that it came down the chute so quickly that it literally got wedged under the pelvic bone. I guess, I don't know. The other moral of the story is, yes, you can graduate nursing school. Yes, you can pass your boards. Yes, you can get a job as an RN somewhere, but don't forget to keep learning. All right? State of Connecticut has no CEU requirements to maintain your nursing license. That's only part of it. All right? I saved a kid's life because of a CEU conference I had gone to. Otherwise, I would not, especially in my panic, have known to do what I did. So, keep learning. Amen. So there's all the there's all the things you're supposed to do. Wasn't my story a better way to remember all of it? All right. So precipitous labor is kind of what started that story. This was her fourth baby, and she was moving along really quick. These are the babies that are born not quite exactly where they're supposed to be born. Like I delivered a baby in the backseat of a Nissan in the traffic circle, or in the the hospital circle in the front. It was a hatchback. So that was fun. I was like leaning on the back of the good times. Also a Spanish-speaking only family. And I can speak Spanish, so that was fine. And they weren't afterwards. Everyone was healthy. Everyone was fine. And they weren't sure if they were going to name their baby Elizabeth or I think Centra, because it was a Nissan.
Oh my God.
That was our joke. Should it be Centra or Elizabeth? Centra's cute, but go with Elizabeth.
We have a family friend he was born on the Hutchinson Parkway,
Mhm.
and his name is Hutch.
Hutch. Yeah, that is cute. So these babies might not possibly be born under the ideal circumstances. In the elevator, into the toilet, in the bathtub, on the floor, in the living room. Yes. Yes. So I didn't feel anything, but by gosh, I felt like I had to poop. Yes, again. Boom, baby born. Yeah. So you have a very overwhelming situation. Oftentimes for these patients, the adult patient is feeling a little overwhelmed and maybe a little out of control because they want to push on the Hutchinson Parkway or in the backseat of a Nissan. Or it's just overwhelming, plain and simple. The situation, the circumstances are not usually ideal. They're not where they're supposed to be. the people who are supposed to be there aren't. So that's one thing. The other thing is that the baby can suffer some trauma from the whole thing, whether it's hitting their head on the porcelain bowl or cold stress afterwards because it's just cold toilet bowl. But I mean, like stuff. So or just the trauma of getting blown out. Yeah. Mom can have trauma from getting a baby shot out of her. Right? So these are all the things we need to consider. It doesn't necessarily mean that everything's all happy-go-lucky. Oh, look, you did everything. Well, the baby could be suffering, and mom could have her, vagina blown out. So. There's some risk factors, like, she's had several babies before. Maybe we caused it by giving her too much oxytocin. Or she just reacted very strongly to the oxytocin that we gave her. There are signs sometimes, obviously, if mom is just like, that lady, the one with shoulder dystocia, she wasn't acting like way out of control or anything. She was in the hospital and things were okay. But there's something subtle, and there's certain people, I don't know what it is. It's kind of like the amniotic fluid. I can't describe the smell, but I know what it is. Kind of the same thing. Like, I just know there's certain people, by the way they're acting, you're getting, I'm keeping my gloves on. Yeah. But there are some signs where things are moving along really quick. And we just have to get ready. We just have to be ready, all right? We just have to have everything that we need to deliver the baby. Like I said, I had all the equipment I needed on that sterile table, but I just wanted to make sure I had the three things that, I want the bulb syringe, a clamp, and a pair of scissors. That's all I really wanted. So I'm going to push everything else out of the way and just have that, You're going to deliver a baby, you're going to lightly support the perineum so that it doesn't get blown out of the water there. So, and the first couple of babies that I delivered are supporting the perineum as the baby's that ring of fire moment. And there's a fine line between supporting a perineum and actually like trying to push the baby's head in. Keep the baby. Please don't come. Please don't stay. Is it somebody who can help me? Don't do that. Don't try to stop what's happening, but do support the area. And then all of these different moves that you're supposed to do. Generally, you're catching a kid. If you're doing a delivery that's precipitous, generally you're just like catching the kid. Sometimes you have the honor of being able to reasonably and gently support the natural birth process in the back seat of a Nissan. But otherwise, it's catching a kid. All right, uterine rupture. Remember last week when we talked about VBAC? So VBAC is controversial because it can increase the risk of uterine rupture. All right, there's been a cut in the uterus, and now we're stressing the uterus not only with a full-term pregnancy, but contractions and pushing maybe. All right, so that's a stressed muscle that's already been compromised with an incision. There are times where there's been spontaneous uterine rupture that didn't have a history of being incised, but in general, it's those who have had either uterine surgery or a C-section that are certainly at higher risk. All right, so a complete rupture involves the uterine wall, peritoneal cavity, and/or the broad ligament, and there's internal bleeding. Basically, a complete rupture means the uterus literally is wide open, and the baby very well might be in the abdomen, like not even in the uterus anymore. Incomplete rupture is a dehiscence of the site. So it's just the, not just, it's still being ripped open. And it could cause some major trouble, especially bleeding, and it could cause some major trouble. All right. Had a woman, another story, had a woman, she had had a C-section. I think she was planning on a VBAC. I don't remember. All I know is that she woke up in the middle of the night in intense pain. Her husband called 911 and they came into the hospital. She was in the fetal position going to shock. So her eyes were non-blinking, and she was in the fetal position and just trembling. And she could not speak. She wasn't screaming. She was just like, it was very difficult to watch, to see that. I mean, nothing compared to her difficult time. Based on her history, we assumed that her uterus had ruptured. So we took her to the OR as quickly as we could. Of course, it was the middle of the night, where they opened her up, and indeed, the uterine incision had completely dehisced. Just the uterine incision. Not one blood vessel, not one bit of the placenta, not one bit of that baby was affected. So everything else remained intact except for the uterine scar. When she woke up, when was able to talk, naturally she said it felt like she was splitting open, in which she really kind of was, splitting wide open. She had a pretty tough time, a little post-traumatic stress, which is perfectly reasonable. And some of us, I gotta say, it was tough to, maybe a little PTSD on our part too. Certainly, both the patient and her husband received some counseling to kind of just work through that trauma, because the poor husband, I mean, just the whole scene was very, very, it was worse, if I can say that. It's worse than somebody thrashing about screaming when they can't even make a sound. It's like she was being absolutely tortured. It was rough.
What they do? Do they sew it back together?
They sewed it back together and said, "Don't even try to get pregnant again." They didn't want her getting pregnant again. I mean, obviously, she could very well do that. It was a perfect incision. It just dehisced right on there was no extra repair to do. It was just the incision that opened.
So did this happen because, so she was pregnant when this happened? Yes.
Oh, absolutely, yeah. She was
Did it
full
happen
term.
because she went too far, like she should have done a C-section prior, possibly?
I think her C-section was scheduled. I don't think she was planning on I don't remember what her plans were, but she wasn't quite yet due. And she doesn't even recall having contractions. Which maybe she was having contractions, or maybe the baby was just too big and stretched the uterus just too much. I don't know. But she woke up feeling like she was being ripped open.
If you had a normal pregnancy and it ruptured through, they could repair that uterus.
But she would still be just as much at risk for a
At
uterine
risk,
rupture.
yeah.
Yep. That's why I say previous C-section or uterine surgery. It could be a myomectomy for something. It could be fibroidectomy, any sort of uterine surgery. Sometimes it's a natural process and the natural stress of labor and pushing that might do it. After a C-section, sometimes we're doing it. Meaning we hyperstimulate a uterus, not on purpose, but by accident, and that's what happens. Pretty much says it all right there. Sometimes the contractions are coming and then all of a sudden they stop. It's not, the pain is there, but there's no more intrauterine pressure because there's a gaping hole in the uterus. Make sense? So we're not picking up contractions anymore. Yet the patient is quite uncomfortable. When a patient has an epidural, it masks the pain a little bit, and that makes me a little nervous when a VBAC or a VBAC, gets an epidural that is so very good that she has absolutely no feeling. I don't want her to be in pain, but I want her to be, I want her to be able to tell me if the pain has changed and is something very different. But anyways, shock. So it could be physical shock from loss of blood, or it could be trauma kind of shock. Get her ready. Get her ready to bring her to the OR. More than anything, that's what we should do. There's your picture. Then you have the amniotic fluid embolism, anaphylactoid syndrome of pregnancy. I am happy to say this is the only complication I have not seen. Pretty good. I've taken care of patients after this situation, but I've never been in the room when this has occurred. Sometimes it's after the baby's born, sometimes it's within, like after membranes rupture, sometimes the patient is still pregnant. The patient, generally what happens, almost all accounts of this, is that things are okay, and then all of a sudden she starts not feeling well. She turns to either the nurse or her support persons and tells them that she's going to die, and then does. Yeah. Circulatory and respiratory shutdown. It's an amniotic fluid embolism. So amniotic fluid, sometimes it's meconium amniotic fluid, gets into the bloodstream and travels up to the lungs and blocks off the pulmonary artery. So they feel anxious, they feel a little short of breath, and then they turn and say, I think I'm going to die. And they go into cardiac arrest. In my, not my experience, because I've never been in the room when this has happened, but in everything that I've read, that's basically how it has gone down. They've not predicted, they say, I don't feel good, I think I'm going to die. And basically they try really hard. Oftentimes they're successful.
Successful in dying?
That die. They are successful in dying.
Oh.
So then sometimes you have a dead pregnant woman where you're doing CPR on. And at one point, you need to make the decision, when do we just take the baby? Do we take the baby by C-section right here in the delivery room? Or do we go, while doing CPR, and go sterilely take the baby in the OR? Yeah, it's pretty tough. It's pretty tough business. Sometimes the baby's already born, which helps with CPR, because CPR on a full-term pregnant woman is not a fun thing to have to do. So it's pretty tough business. And then once they are revived and resuscitated, if they are resuscitated, usually they go into DIC and all sorts of things. So it's a pretty long and torturous recovery for those patients. And sometimes the whole ride hasn't been all that fun. So these are patients who are at, perhaps having other complications within their pregnancy. So that kind of sucks. Heck of a way to end a pregnancy. So yeah, client may report sudden chest pain, may see signs of respiratory distress, coagulation failure, and circulatory collapse. We're going to do everything we can, you know. If she hasn't quite gone out yet, we're going to put her on her side and do what we can to support her and be ready for complete CPR. Okay.